we'll go ahead and get started. All right. What's well, I'm Hayden. I think I've met all of you, but what'd you say?
Look at that, it worked.
Yeah, magic. I do PowerGlides, and I watch a lot of YouTube, and that's why I'm qualified to teach this class. So I just tell everybody most of what I know is just from just doing it over and over, and then watching a lot of YouTube videos. So if you want to learn more after this, there's tons of anesthesiologists who just have downtime apparently and just make lots of YouTube videos. So really cool tips about how to get the little veins in your wrists to pop out, to the proper way to use certain kinds of angiocaths. We have a certain kind, some docs like to actually bend their needles. You can't do that with ours for a certain reason, but YouTube's a great resource. So what's your experience with placing PowerGlides? We'll kind of, or actually let me do a quick caveat. This is not a PowerGlide class. I'm gonna slip up and keep saying PowerGlides because that's what I mostly do. But this is an ultrasound peripheral IV class. And so after this class, you're trained to place these long catheter IVs and the short ones using ultrasound. To do the PowerGlide class, you have to take a class by BD where the rep comes in and teaches you how to actually use the device. And so after this, if you found it helpful and you want to learn more, just let management know the next time they do a class. They're always looking for people to take to learn more. Yeah. So what's our exposure to the ultrasound? Have you ever played with the ultrasound? Is it brand new? Yes.
Not brand new.
Not brand new. You have played with it. What about you? It's Abigail, right?
Yeah.
What about yourself?
It's brand new. I've just seen people do it.
Okay. How many times have you seen someone use it?
Maybe 3 times.
Okay, that's good. That's good. Yourself?
I've used it
Okay.
under supervision.
Okay. What's our success rate? Because it's only going to go up from here, hopefully. just out of curiosity.
I only put one in with the ultrasound.
Okay.
And that was after having someone teach me everything about it.
Yeah.
And then they showed me how to use it. And then
Great.
they were like, well, why don't you do this one?
Yeah.
So 1 for 1.
There we go. 100%. I mean, I guess you can't get better than it. So.
You gotta go down.
Yeah, only down from here. So the reason I ask is because if you were doing a couple and you were getting them and you had a technique that was good, I'll show some techniques in here, but if it was working for you, then that's great. That's one thing about this class too, is most of this PowerPoint is techniques that, well, I've talked to a lot of other nurses on the unit, Kaylee, Jamie, other nurses, and gotten some tips from them about techniques they use. So everyone kind of has their own personal flair about how they use the ultrasound. Because really it's just practice and time, you kind of develop your own skill. So, Gay, what about yourself?
I am one in the same boat as her.
Yeah. All right. Sweet. Matt?
I use it a lot.
Yeah. Matt's a wizard.
Not a wizard, but yeah.
Kaylee, what about yourself?
I use it a lot.
Cool.
I place PowerGlides
Yeah.
a lot.
Kaylee's hoping to teach this class after me, so she's here to kind of see how the class goes.
See if I'm qualified.
What'd you say?
See if I'm qualified.
See if you're qualified. I say so. And there's Lori. She's second hand today. She's gonna do the other block while I do one once the lecture's over. So she's PowerGlide checked off and also a IV wizard. Cool. All right. So objectives. We're gonna place ultrasound IVs. So there's 2 policies I handed to you. The reason I put them in there is just so that you guys know that there are some of this stuff is directly from our protocol, things like using chlorhexidine when you prep a site. So you've at least seen them before, and you can reference them again if you'd like. Catheter selection. So actually, I'm gonna buzz through. So selecting your catheter. So the first thing you got to think about is, what am I using this catheter for? And are we using it for blood draws? Are we using it just for IV famotidine once a day? What's the intended use? Because that might inform what kind of a catheter you end up choosing and what kind of vein you end up going for. So Also, is it a large vein? Is it a small vein? If it's I did this actually just before I came up here. There was a tiny little vein, and I wanted to use an 18 gauge because the 18 gauges PowerGlides are longer, but I had to use a 20 because I thought that the lumen of the catheter would occlude the lumen of the vessel. So, welcome. Grab a seat. So yeah, just some things to think about, and we'll kind of learn more throughout the PowerPoint about how to pick an ideal catheter. I literally, the last patient I just came from, her arm looked like that, and so I had to use the longest catheter we have to do it, and it was a stretch. One important thing about arms that look like that, where they have pendulous triceps, if you displace the skin to get, like, sometimes if you like twist their arm a little bit and then you look with the ultrasound, it will look like the vein is more superficial, but then once you release the tissue, that vein kind of falls back deeper, and it can actually that catheter can get pulled out right after you. So sometimes someone will place an IV, it's great, draws, flushes, whatever, they take all their stuff down, and then they go to use it and it doesn't work anymore, and that's sometimes a reason. So just whenever you place an IV, try to place it in a natural position. Like put their arm in a natural position before you place it, so that it's ideally going to work exactly like it did when you first placed it. And then I'll show you on the ultrasound a little bit later how to measure how deep a vein is. That way you know if it's too deep to go for, if your catheter is not going to be able to reach it. And then also sometimes when you're looking at a vein, you can see that it ends up splitting, or maybe it takes a deep dive or something weird, and it actually that would indicate using a shorter catheter, because you can't. It would be a longer catheter would either like deviate or it would go down a bend and then actually kink off and be unusable. Something to think about. Oops. All right, here are our tools in our toolbox. Again, we're not doing PowerGlides, but I just put them up here for reference. So this is what I just had to use on the lady with that kind of an arm. That's I mean, you can see the difference between what we normally put in patients, the 20 and 18s over here compared to the 10 centimeter. It's quite a difference. So this is what we're normally going to use, an 18 or a 20 gauge long IV when you're using an ultrasound. And today we have 20 gauge longs that we're going to use on the blocks. And we also have 14s and 16s. Anesthesia carries these around. That's how I found a 14 gauge. Yeah, I don't put 14 gauges in unless you're going to be running massive transfusion through it. There's no reason for it. So, but yeah, those are all the different ones we have. So earlier I mentioned you don't want your catheter lumen to occlude the lumen of the vessel. The reason for that is you want good blood flow still to dilute the medications that you're putting through that catheter. If you don't, that medication, first of all, it's not getting flushed back to the patient like it should, and it could actually if you have a concentration of that medication build up and it extravasates, then it's just a worse situation. So pick the smallest catheter you can for the job, and don't occlude the lumen. So here's a quick side note on PICCs versus midlines. This is all kind of a gray area, but for here at Eskenazi, we really don't use midlines. And when you do see if you do see a midline, what it is is a PICC that they actually take while they're sterile and they cut so that the tip of it terminates before the bend in the axilla of the arm. And so it's actually a peripheral IV and should be treated like a peripheral IV, but it's intended for long-term use, just like a PICC is. So it's kind of misleading, but on the PowerGlide packaging, it says PowerGlide midline catheter because there's like some FDA definition of what a midline is that technically, if you put a PowerGlide in a certain place, it could technically be a midline. And so they label it like that. I think they can probably charge more money. I don't know. But when you see a PowerGlide on your patient, it is not a midline, it's a peripheral IV. and you treat it the same protocol for changing dressings, what you can put through it, all that kind of stuff. Yeah, and PICCs terminate centrally, hence the central catheter in the name. And it might have multiple lumens. That's something that's unique too. Any questions over that? Yeah. Cool. All right, vein selection. We touched on this earlier, but intended use of the IV. Are you drawing labs? Do you have frequent labs? Are you just putting normal saline through it, or are you like sometimes on II you might need to start norepinephrine before they come down to ICU, and that might indicate a new IV because you don't trust the one you have, and that, in my opinion, you would want to choose a vein that is more superficial than one that is deeper, because if your norepinephrine breaks out into your tissue, you're going to notice the injury sooner if it were in like the top of the hand or the forearm than if it were deep in their upper arm. Then they might actually end up losing their arm as opposed to just losing some tissue on the top of their hand. So that's kind of something to think about. What are you using this access for? Also, if they have arm precautions, like if they've had a mastectomy, which, do you guys know why you don't use arms that have had a mastectomy on that side?
I've wondered, I've never known.
It's because they remove all the lymph nodes, and they can't process, if there's extravasation, they can't process that fluid. It just hangs out there. They can't get, the lymph system is what helps promote the, yeah. Learned that a couple weeks ago. Health of the veins. If you get an IV drug user and they got those crunchy, scarred up veins, don't go for that. Try to find something that they haven't found, and place something in a healthy vein. And then also, the vein preservation is something that we're kind of touching on, where a lot of our patients might end up needing an AV fistula for dialysis, and we might want to preserve their upper arm, their brachial area, for an AV fistula in the future. Also, again, I feel like I keep saying this, but we'll talk a little bit later about that area. There's nerves, there's arteries, there's veins. There's a lot of stuff in there, and so it's ideally avoidable. Try to get something in the forearm for many reasons. Oh, and then avoid places of flexion. AC IVs really probably should come out sooner than later, because what happens is, especially if they're conscious, every time they bend that arm, that catheter is butting up the wall against the wall of that vessel and causing inflammation. It's causing trauma and inflammation, and over time, it's just going to lead to injury, and you get phlebitis, and you get extravasation or infiltration, and can cause issues. So try to get an IV in a place that does not have a place of flexion. And something to consider too is when you have a long IV, if you place it here, that's not in the AC, but the catheter actually extends past the AC. So that's something to think about too. You might want to go a little bit further down the arm. Here's some nice veins. My personal favorite is the cephalic vein. It's usually superficial. I'd say 90% of people have a nice one that you can go for. There's no veins, there's no arteries near it. It's kind of all by itself, snuggled in between the two biceps. Yeah. Yep. All right. To tourniquet or not to tourniquet? This is Jamie's thing. Is it your thing too?
Sometimes.
Yeah.
Especially with old people who
Yeah.
have a history of their veins blowing,
Yeah.
either really loose tourniquet or none.
Yeah. What is the purpose of a tourniquet? For vascular access, or why do we use a tourniquet?
Doesn't it cause backup
Mm-hmm.
of blood?
Yeah.
So then it causes things to pop up that wouldn't normally pop up if blood was just flowing.
Yeah, engorgement of the vessel is a fancy term to use, but you're right. Yeah, it makes that vessel bigger. And like Lori was saying, on an old patient who's got fragile veins, if you engorge their vessels and then you poke it, what happens all the time? I had a great vein and I don't know what happened, it just blew. they just have brittle veins, and you poke that with a needle and it just pops and it busts open. So sometimes it might actually be advantageous to not use a tourniquet and place an IV. It's a little tricky sometimes, but it's something to think about. Do I really need, because sometimes you'll look at a patient and their veins are like that big, and you're like, holy smokes, and then you take the tourniquet down and it's gone. You're like, oh, okay, I guess I do need a tourniquet here. So, yeah. Something to think about. Any questions over what we've talked about? That beginning part's kind of just a bunch of random stuff kind of lined up together. Cool. Ultrasound assessment. So this is a Sonosite machine. The website has a bunch of cool animated videos that are really helpful. Different procedures. They have maybe one or two on vascular access, but they do ones on arterial lines if you're just kind of curious about like how your residents should be doing arterial lines. There's some good resources there. This is kind of what they look like. So they're animated. They kind of give you an idea of how of the anatomy underneath your probe, which is kind of fancy. This is how ultrasound works. So it sends sound waves out, and it'll hit your tissue objects, and then it'll bounce back. And then there's a receiver in the wand that will then use a computer to generate an image based on that information. And so that concept's important to remember as you think about the image you're seeing, because the image you're seeing is not necessarily always true to what is in the patient, because of the nature of using sound to create an image. Yeah. So one key, there's like 3 things I want you guys to remember from this class. And the first main thing is always know where your tip is. If you lose your tip, you gotta find it before you do anything else, because otherwise you're just poking around causing trauma, and you'll inevitably hit your vessel, and then you'll cause some bleeding, and then that just kind of makes it even harder and kind of a disaster. So always know where your tip is. It's not hard, and I'll show you a couple different ways to kind of play around with the ultrasound probe to be able to figure out where it is. So it looks on this device, it looks just like a really white, sometimes it kind of looks like a downward arrow, or I guess sometimes an upward arrow. It kind of depends on what angle you're at. But yeah, it basically just looks like a really white speck amongst all the other stuff. And you'll see tissue displacement as you advance it too. That's another way to kind of tell where you're at. But you want to see the tip. So, like I said, with using ultrasound, sometimes your probe will be over tissue or objects that don't allow sound to go past them. And that shows up on your screen as a shadow. So one of the ways to know where your needle tip is if you see a shadow like here on your screen, that kind of should tip you off to realize that your probe is actually over, if this is my needle, is over the body of your needle and not over the tip. So if you're seeing a shadow, what you need to do is advance forward until you lose that shadow and you see the tip. Sometimes, I know I keep talking about this case, but literally the IV I just placed before I came up here, I couldn't find my tip at all. I couldn't see it, but I could see my shadow. And so I would go until I lost my shadow, and then I would advance my needle until I saw my shadow again, and that's how I ended up placing it, because I could, for some reason, I couldn't see my tip on my ultrasound. So, and then if you go the other direction on it, so instead of perpendicular, you go parallel, it might cast a shadow along the length of the needle like that. So, kind of a nifty little trick. So our ultrasound here. So we've got, I'll just kind of let's do. So we've got our probe, and this is, I don't know, maybe if you guys have a better way to explain this, help me out. But we have our orientation marker. So there's a little nod or like little bump on the side. There's a little, thing here, and there's a little thing there. There's 3 different markers to show you, left versus right. And the reason that's important is because when we're looking at our image, we want our left on our screen to be left based on where we're at on the patient. Because, and the way you know that's lined up is the orientation marker is on the left and this little blue dot's on the left. If we switch the blue dot to the other side, now what that means is we're actually seeing an inverted image. So the left is on the right and the right is on the left. To fix that, all you gotta do is make sure your orientation marker is on the same side as your screen, as that little dot on the screen. And what's gonna happen is you're gonna be looking at your patient and you're gonna be going side to side, and you're going to be all confused because you push your needle this way and on the screen it goes that way, and you're like, why is it, this is not heading in the right direction, and then you look and it's, oh, and flip your wand around and then boom, you're going to be left is left, right is right. Does that make sense? And then in the center we have the center line, but that also doubles as a measurement tool. So each dot is a 1/2 centimeter, and so there's small dots and big dots. The big dots are 1 centimeter points. So 1/2, 1, 1.5, 2, 2.5, and then down here it actually says 2.6. So it tells you the total depth view of your screen here. The dots are also on the side, right here. Yeah, for reference. And you can take the center line. So I thought you could take the center line away. Yeah. And then these little knobs. The one on the left is basically your contrast or your gain. And so when you turn it up, it's going to basically turn the brightness up. And so you want to make sure that you can see your image clearly, and so you want to adjust that. Usually when you turn it on, it's set to an automatic level. I actually almost always turn it up a little bit. And then the other side is your depth. And so it can go as shallow as 1.9 centimeters and as deep as 6 centimeters. And in reality, you'll only really use it between like 2.2 and 1.9. So those two shallow levels, because your catheters won't reach much deeper than that. Yeah. When we place IVs, it's supposed to be an aseptic technique. It's not sterile. So you do have to cover your probe. It does not need to be a probe cover. If you want to use a probe cover, you can. That's not, that's not wrong. But right now what we're doing is we're just using tegaderm to cover the tip of our probe. So when you get the tegaderm out, just make sure you don't touch that face of the tegaderm. It's kind of reverse. Normally we want the sterile part to be the sticky part, but in this case we actually want the face of it to be sterile because that's what's going to be touching the patient. So you get your tegaderm out. You can use gel on your probe, you don't have to. So it can be dry and you just put it on really tight and then just stick it to the wand, and then that's a sterile surface now, or an aseptic surface. And then it just looks like that. So that way, I mean, if you think about it, this has only been cleaned with what do we use? Hydrogen peroxide. And then you're just, rubbing that all over. Like, we really should use a sterile surface. So, and that goes from patient to patient. Chris? Questions on any of that? Okay. Using your probe to your advantage. So there's two views to use with your probe. There's the short axis or perpendicular, and then the long axis or parallel. And both, you'll 98% of the time use the short axis, but the long axis is helpful in certain situations, and I'll show you why. So we'll talk about these. So using your probe to your advantage in the perpendicular view. The way I like to explain this is if your setup looks like this, think of it as if you're looking at a loaf of bread, and the image on the screen is the face of that loaf of bread. And so that's what our image is going to look. You can see the full lumen of the vessel. You can see, all the way around, which is really nice to know how big that vessel is. And so this is another view of what it might look like. So you can see the full lumen of your vessels, but you can also see the lumen of your catheter when it's placed. And then as you slide up and down the arm, you'll see different veins also join in together or even sometimes split off. And that can be helpful in a thorough assessment of your patient's vasculature. In the long axis, it's kind of like a sub sandwich. So instead of looking at, cutting it short ways, we're cutting it long ways. And the view you're going to see is the floor and the ceiling of your vessel. And the reason, the reason this view is not as helpful is because what we're seeing here, if this is the vessel and this is our probe, okay? This is the image that we're seeing right here, okay? The floor and the ceiling. So we're seeing right here the full length of the vessel. But what happens if you don't really, if you're kind of off center and you're actually viewing this right here? It's gonna look like a much smaller vessel, your target's smaller. And so it's harder to land a good IV in the middle of the vein at a smaller target at that than it is when you're in the perpendicular view and you're actually seeing the full limit of the vessel, then that's what you're aiming for. Does that make sense? Cool. This view is helpful for confirming placement. Actually, I think the next picture. Yeah. So it's kind of cool. You can see your needle literally enter the vessel. You can see this is a guide wire, but you can see your guide wire or your catheter actually lay within the lumen of the vessel. And then if you flush it, you can see the turbulence come out the end with the saline. It's kind of fun. Questions on those two views? I always use those two views, obviously to place it, but then to confirm after I pull my needle out and I attach my saline. But whenever someone calls me, it's like, hey, I don't think, my PowerGlide's not working, my IV's not working, can you just take a look at it? The first thing I do is I obviously flush and draw, and if that looks okay, then I look with the ultrasound and I'm like, oh yeah, or like, oh, I don't need, this looks kind of sketchy, let's just pull it out. So usually with those two views, you can get a really good idea of what your vessel, your catheter placement looks like. All right, anatomy. So color coding, veins, nerves, arteries, and then we'll see some bones as well. So this is cephalic vein, so upper arm here. Do you guys think you see the vein or artery or nerve? Think so? Here's a little blue arrow. So this is compressed, and it's labeled, and then uncompressed. So when we're just looking at it versus when we push down on it. And the reason that's important is because arteries pulsate, right? And so while we compress it, you can't see it in the still image, but when you compress it, you should see a pulsation of an artery, and those veins should just collapse underneath that pressure, and they should not pulsate. Sometimes you can't collapse a vein all the way if their blood pressure is really high, if they're really fluid overloaded, but it shouldn't pulsate. And sometimes you'll get veins that don't collapse at all, and those are just really unhealthy veins, and you probably should not go for them. That's usually when you see an IV drug user, and you can see their veins because they're all scarred and they're just rock hard. And if you try to poke, it's going to be crunchy. It's just it's not good. All right, this is the antecubital space. This one's maybe a little bit more obvious. We've got a lot going on here. So like we talked about, we want to avoid this space, but for learning anatomy, it's helpful. So we've got two veins, one here and one here, and then we have an artery. And the way you know is because when it's compressed, it actually stays inflated and pulsates.
I was gonna say, on the left one, I couldn't tell which one.
Yeah.
I figured they
Yep.
run together, but I couldn't tell because it's still shut.
Right. Yep. And when you're doing it on your ultrasound, it's way more obvious. So, and then interestingly enough, I didn't see it until I compressed, but there's a nerve right here too, the radial nerve, and nerves look like honeycombs, and you'll know when you hit them because your patient will freak out. And avoid nerves. Obviously, we're not catheterizing nerves, but if you hit a nerve, you can cause peripheral nerve damage that can be permanent. So you can harm your patient. So just look somewhere else if it's not a good option. And then here's the brachial area. Give you a second to look at it. Decide what you think. All right. So we've got a vein, collapses under pressure. Do you guys think that was something? I think that's kind of, when I first looked at this, I was like, oh, maybe that's a vein, and maybe I'm compressing it, but then when I compress it, it didn't change. So I'm like, oh, that's clearly not. So, got a vein there, artery there, and then the humeral shaft right here. Have you guys ever done like an arch stick and like hit their bone before? It's the cringiest thing. It just gives me the
The
heebie-jeebies.
little bitty skinny one.
Yeah. Oh.
With some shower.
Funny hitting a bone story. There was this motorcycle accident I came up on a couple months ago. You guys know if I heard this story. But did you hear this, Matt? No?
I don't know.
So the two people on this motorcycle, this has nothing to do with vascular access, but they were like laid out on the road. This was like 5:15 a.m. And so I got out, and the ambulance wasn't there yet, and no one was doing anything. So I like start checking these people out. They both had open fractures, and I was like, making sure one was helmeted, one was not. The girl who was not helmeted like hit the dude's helmet with her face, and she just like bled all over. But I went to go check the dude out. They hadn't lost consciousness or anything, so I wasn't like super worried about like a head bleed or something. But then I went to go, got the girl out of the road, and then I went to go check the dude out because he was like still laid out on the road, and was like feeling his arm to make sure I didn't grab, on a fracture. So I went to lift his coat up and literally scraped his radius sticking through his arm with my bare finger, and just like took a moment. It just like the heebie-jeebies just went full through me. So I think they were fine, honestly, just open. He had a left, open fracture, and she had a right lower extremity open fracture. So it's what the classic situation where they're holding their leg and their lower legs like hanging out like that. Yeah. All right. Anyways, and then I ran into another motorcycle accident like 2 weeks later. I don't know. All right. When you have a vein above an artery, try to avoid it, because what's inevitably going to happen is you're gonna get that vein, great job, and then you're going to be a little overconfident, and you're going to puncture through the bottom of it and go into that artery, and then you've accidentally created a fistula between that artery and vein, and you can cause some complications for your patients. So if there's another option, like a big old juicer to the side, just go for that one. It's also shallower, way better option. Something you'll see too is when you're looking at vessels, like if this is an artery and this is your vein, the vein, as you go up and down the arm, will kind of change position. So sometimes they'll literally kind of do circles around the artery. And so sometimes you can just like go further up the arm, and then it's on the side, and that's a better place to go. Again, avoid it if you can. Avoid the upper arm if you can. Sometimes we don't have an option, but yeah. Questions on the anatomy stuff? No? Watch when your docs do central lines, because they don't like use any of these. They just kind of just throw their thing on, and then they just kind of poke around, and it's a little embarrassing once you kind of know what you're looking at. But I actually gave a doc a pointer the other day when he was doing an art line. He failed like 3 times, and I was like, oh my gosh, this is killing me and the patient. Probably not literally, but and I gave him a tip, and he used it, and boom, he got the art line. And he was humble enough to like receive the constructive criticism, and it actually helped him out. So you know a little something or thing about ultrasound, so be willing to teach. Preparation. This is chlorhexidine. Got to use it. We are out, so they are stocking us with iodine, I want to say, povidone or whatever it's labeled as. So I guess we're using that right now. I don't know. But in a lot of the kits, or I guess a lot of the supply rooms, they do have the wands that, like with the orange dye. So really try to use chlorhexidine. That's the best option. And then don't take the cap off your extension tubing. Maybe pop it off and then put it back on so it's easier to get off. But what's inevitably going to happen is you're going to put that down, and it's just going to touch the blanket or something and become unsterile. And then I tape every patient's arm that I start an IV in, because it just makes it easier. Sometimes I'm like literally taping it up in the bed like this, or I'm just taping it out on the bedside table, or I'm just taping it to the railing, putting a towel between their hand and the railing. Just makes it so much easier. Then if they move, there's less movement. And Yeah, ergonomics. Raise your bed up. The one time you don't will be the time that you're stuck like this for like 20 minutes trying to get that IV and it just hurts. And there's our classic, landing the plane. I don't know, is that a good description? I don't know. No one's got a name for it. Because this one you hold like a pen, that just makes sense. But for shallow veins, land the plane. For steep veins, you want a sharper angle, like 30 to 45 degrees. And so use a pen hold. Yeah. Some people like this hold because then they can use their finger to slide the catheter forward. In my opinion, however you hold it, you should just keep that hand perfectly still and use your opposite hand to advance that catheter. That way you make sure you don't accidentally advance your needle at all. Proper catheter placement. So you want as much of the catheter within the vessel as you possibly can get. And you want no less than half of it in the vessel. And the reason for that is if prevents dislodgement, which then prevents extravasation, and it promotes good blood return too. So, which is kind of a lot. So we'll talk about the geometry of it here in a second, but yeah. So I made a mistake when I was making this PowerPoint and that I didn't want to remake it. So this is technically a PowerGlide, an 8 centimeter PowerGlide. The principle still remains the same. So, do you guys remember Pythagorean theorem from geometry? A squared plus B squared equals C squared. You don't have to do that to place ultrasound IVs, but the concept, you're using it here. So, thanks geometry. I think my geometry teacher was Mrs. Stiglitz. Yeah. So if your probe is at 90 degrees, if your probe's at it was she was nuts. She was crazy. She smoked like 3 packs a day. I can't remember her name. She was nuts. Hold your probe at 90 degrees, and if your vein is at 2.5 centimeters depth, then based on the math, it'll take 3.5 centimeters of length to get to that vessel at a 45-degree entry point angle. So, and that's just to show that you have over half of the catheter in the vessel, but we're going to be using a slightly shorter catheter. And you really should not be going for veins that are deeper than 1.5, maybe 1.75 centimeters. At that point, you run the risk of not getting half of the catheter in the vessel. Yeah. So, kind of a helpful concept to keep in the back of your mind. Yeah. All right, here's a little animation. So when you're setting up, you got your probe, right? And you line up your arrow the arrow on your probe correlates with the central line on your screen. I don't think I showed that earlier. So your probe's gonna have an arrow. And so if you put your needle entry point at the arrow, it's gonna be right on center line. So if you've got all that lined up, you're ready to insert. But one technique that's really helpful, this is what I showed that resident that he ended up using to get that art line. If it's a really shallow vein, you want to fan your probe. Fan your probe towards yourself, because you're going to see your needle tip sooner than if you had to actually puncture the skin and travel all the way to underneath the probe sensor. Does that make sense? Because the probe, the view you're seeing on the screen is a paper's width view, and it's coming out of the middle of the probe here. So you have to travel the whole distance to the halfway there before you see your needle on the screen. And sometimes your vein might be at that same depth, and so you won't see your needle until you're at the vessel depth or past it. So if you angle it this way though, you'll see your needle tip sooner, and then you can know where your needle tip is prior to getting to your vessel.
That's on shallow.
On shallow vessels, yep. Which is why it was helpful with that art line, because those radial arteries, it was on a tiny old lady too, and it was just so small. So, fan to see your tip when you enter. Yeah. So when you do insert your needle, hold that probe still, advance your needle until you see it appear on the screen here. And then what you're gonna do next, well, hold on, that was, yeah. So advance your needle until you see it, and then hold your needle still and advance your probe. And I'm talking like, people all the time will just be like, whoop, like they'll move the probe like 2 or 3 centimeters. I mean, I'm talking literally so ever slightly, basically until you lose sight of your needle. The smaller the stair steps you can do, the better. So it'll be more smooth. You'll just have more opportunity to adjust your angle and everything. So advance your probe, and then hold your probe still and advance your needle until you see it appear. And then just keep doing that until you see the needle get into the vessel. So once you get into the vessel, you should see flashback in our catheters. And you should see your tip in the vessel. Even though you got flashback, does not necessarily mean that you got the catheter in the vessel. And I don't know if you guys noticed with the PowerGlide, but the bevel, the catheter sits like maybe a 0.5 millimeter behind the bevel. You see that?
Mhm.
And so when you get flashback, can you see it all the way back there? So when you get flashback, you see how far back the catheter is?
Oh, yeah,
Yeah.
okay.
So when you get flashback, that does not necessarily mean that your catheter has to be in the vessel. Otherwise, literally, it'll bump up against the wall of the vessel, and it'll be difficult to advance through. So what you need to do is you need to then walk your needle in your vessel, and what that means is you're in the vessel, but now what you need to do is lower your angle and use the same technique to just watch it go down the length of the vessel, and not far, but far enough that you're confident that your catheter is in the vessel. And then what you do is you throw your probe down, you just slide that forward, and you're good. Which I think is my next slide. Lower your angle, advance your catheter. Yep. Questions on the stair stepping? Slow is smooth, smooth is fast. So confirming or visualizing your catheter. So here with the perpendicular view, you can see the lumen of your catheter, but then here in the parallel view, you can see the tip of your catheter within the vessel, which is really helpful to see. And just kind of, it's just satisfying.
Can you see valves?
Hmm?
Can you see valves?
So here's the thing. Valves are kind of in terms of valves being an issue, they're kind of a myth based on what I've been taught. You really don't run into issues with valves. So maybe once in a while you might see something, but personally, I don't know, maybe you guys have some input. I can't say I've ever seen a valve on ultrasound.
But it's just because the catheter is getting stuck to the side of the wall, like the wall of the vessel then when that, because sometimes you feel like.
Yeah, so what can happen is as you like create suction, it collapses the vessel.
Yeah.
So maybe that's a valve, maybe it's not, but I can't say I've ever seen a valve on ultrasound or seen it be a problem on ultrasound. Or when I'm advancing my catheter, I've never like run into a valve, you know, it's like, I don't know.
Usually you're in it and you're in. If you're not getting it smooth, then you're
Yeah.
not completely in.
Yeah, yep, yeah.
Or you're at like a slip. And
Yeah.
it'd be from you.
Yeah. That's one good thing I don't think I have in here that I should probably add, but when you advance your catheter, like Kaylee said, it should be smooth all the way through. It should be smooth all the way through. If it's not smooth at the beginning, it might be because you're not far enough in there and your catheter's buttoned up against the wall of the vessel, even though your needle's in the vessel, so maybe advance a little bit. But if you're like having to push hard, if it's not smooth, you're not in there. Don't even attempt. So, yeah. I had this crazy situation I just remembered probably a year and a half ago where there was a PowerGlide. It was the only access the patient had in that part of their arm, and I'm looking on ultrasound and I'm seeing 2 lumens on the screen, and I'm like, how are there 2 catheters in this patient and lo and behold, the catheter had turned in the vessel. I don't know how in the world that happened. It literally completely turned, and of course the catheter wasn't working. But yeah, it had totally flipped around. Thank goodness it like kind of unraveled itself as I like DC'd it and it came out. But I was like, oh my gosh, how in the world does that happen? But again, assess with the ultrasound, and you might be able to see that kind of stuff. When you flush with saline, this is actually contrast. It's kind of an exaggerated look. But when you, just like, have you guys done a bubble study with doing a TTE with the Ecotechs, where you like make the bubbles and then flush the bubbles?
May I have your attention, please? Code Blue Hospital, 8th floor, room 114. May I have your attention, please? Code Blue Hospital, 8th floor, room 114.
So when you flush, there's micro bubbles and there's turbulence, and you can see that on ultrasound. And so they'll do that with a echocardiogram to see if there's communication between the ventricles, if they have like or even atria. But we use that same technique, just causing turbulence and a little bit of micro bubbles to see if you're in the vessel. So you take the ultrasound, you go past the tip of your catheter, and then you flush, and you see the vessel kind of, engorge. Oh, I should give this back. Yeah. Questions on that? Cool. All right, we kind of already talked about this, but remove unneeded PIVs. If it hurts the patient, it's a bad IV. It doesn't matter if it draws, doesn't matter if it flushes well, doesn't matter if it's been a great IV for you. If it hurts your patient, it means there's inflammation, it means there's damage. Get it out. Assess them regularly. We've got some pretty crazy stories where patients had IVs that were they were charted as assessed, but no one actually really looked at them. And it caused, detrimental damage to patients because...
May I have your attention, please? Rapid response team needed, hospital, 8th floor, room 114. May I have your attention, please?
That's the same room, right?
Rapid response team needed,
Yeah.
hospital, 8th floor, room 114.
All right, that's it. We'll do hands-on after I show you these cool pictures. Any questions? Okay. So why does this matter? Here's some extravasation. This is propofol. Owie. Epinephrine in the hand. Kind of looks like a frostbite patient. Yeah. That's why I heard this story from a nurse. Their first med era was technicians used to do digital blocks with lidocaine, and they accidentally got lido with epi, and so their finger like turned white, and they like could have lost their finger. They were okay, but yeah. Contrast eye. Ooh. Oh my gosh, you guys. We admitted a patient today who I'm not kidding, had a black head that big on his chest. Like Dr. Pimple Popper quality. That just reminded me of that.
Somebody pop it.
No, you need a scalpel to get that thing out. It was crazy. And it looked like a cat's eye too. Like the middle, the black head of it was like kind of a, I don't know, like a, oh my gosh.
You know that within 48 hours, somebody.
That's gonna be gone.
Oh, yeah.
He's gonna have a gaping hole in his chest though. They're gonna be like, what's this wound? And someone's gonna have to be like, I picked the black head. So this is kind of interesting. So this is where the IV was, great thumb IV. Well, it extravasated, and they had their ID band, and their ID band actually acted as a tourniquet and caused compartment syndrome in this patient. Yeah. Ouch. Contrast in the arm. And I don't remember what this is, but you can clearly see this is where the IV was, and then it just kind of, disseminated. Dopamine.
So if you notice an extravasation.
Yeah.
And you call the pharmacy, they're going to most likely give you, if there is an adjuvant, correct?
Yeah. So call pharmacy, and I think there's just a protocol that they look at, and sometimes don't take the IV out, stop the medication, because they might actually have you infuse the antidote through that IV, if there is
And
one.
don't flush it.
Yeah, don't put more of that medication in there if you don't have to. Well, you don't have to. And I will tell you, every time I've called for an extravasation, they just tell me put a warm compress and elevate. I don't know. Have you guys ever had? Has anyone ever had an antidote?
Yeah,
No, there's been,
No.
I can't
Shots.
remember what the drug was.
For what?
the shots.
Really?
I think
What?
it was a
what'd you-
pressor.
Really?
Yeah, I've had a doctor come in and they come in and they put like injections.
remember what it is.
Like subcutaneous injections. on
Interesting.
them.
For a vasopressor?
I don't remember what the drug was. It wasn't my
Interesting.
patient. But I remember them coming in and if I wanted to watch it.
Yeah. Yeah.
And yeah, I was just like, like when they numb stuff up, that's
Mhm.
kind of like what they did in the school.
Interesting. Cool. I made a little YouTube video if you ever want a refresher or show someone else. Again, there's plenty of stuff on YouTube. You don't need to watch mine, but
And
We're-
what views do you have?
oh, like 13. They're all from my class. We're just going to watch a short part of it so that you can see what it looks like to walk the catheter in. And it looks pretty good, nice and straight and big. So what I'm going to do is I'm going to line up my center line. I'm going to arrow on the probe. I'm going to fan my probe so it points towards me just a little bit more. And I'm just going to barely puncture the skin. And until I see my needle tip right there, you can see it, that white dot. Then what I'm going to do is I'm going to straighten my probe out. You're going to notice I'm going to lose my needle tip. I'm going to advance my needle until I see it show up again. Then I advance my probe just a little bit, advance my needle. There it is. And you see I'm going towards the side a little bit, so I'm going to adjust my trajectory. Advance my probe, advance my needle. Slowly. There it is in the lumen of the vessel. So now I'm in the lumen of the vessel, so what I'm going to do. Alright, so here is a demonstration of inserting an IV catheter using ultrasound. So here's what it looks like on the surface.
You're going to straighten your probe out and then advance your needle until you see it appear. Then advance your probe and then advance your needle until you see it appear again. Then you're going to continue this until you see it enter the lumen of your vessel. Advance your needle, advance your probe, advance your needle, advance your probe. Very small increments will make it easier to do it successfully the first time. Lower your angle and make sure that you advance your needle into the very middle of the lumen, and then you're ready to advance your catheter.
What I want to show now is, boom, there we go, let's do it. Any questions before we get going?